year med student here at LSU. I'm also a board member of Louisiana Addiction Research Center, what we call LARC. I just want to say quickly thank you for everyone that's participating today and in the future. If you have any comments, concerns, anything, you can go to our YouTube page where this is where we have a live feed, and you can leave comments live, or you can go to our comment section on our website later. So I want to go ahead and introduce our experts. So first we have Dr. Nicholas Getters. He's a professor and chair of the Department of Pharmacology and Toxicology and Neuroscience. He's the executive director of LARC. And then we have Dr. James Patterson, the professor and chair of the Department of Psychiatry and Behavioral Medicine. He's the clinical director for the Louisiana Addiction Research Center, or LARC, and he's also the chair of neurobiology at Christus Shumpert. And then finally, we have Dr. Kevin Murnane. He's the associate professor in the Department of Pharmacology, Toxicology, and Neuroscience, and the Department of Psychiatry. He is also the Basic Science Research Director for the Louisiana Addiction Research Center. So I will turn it over to you, Dr. Getters, if you want to tell our audience a little bit about LARC and who you are and why you're here today.
Sure, thank you, Anna. The Louisiana Addiction Research Center, or LARC, is one of the newest centers at LSU Health Shreveport. And we're becoming a leader in addiction research, which is why we have research in our name. And what we plan to do is collaborate not only here on campus with other basic science and clinical departments, but also with the other research centers, the Cardiovascular Center, the Cancer Center, the Center for Brain Health, and other centers here in order to learn more about addiction, to provide a multidisciplinary approach to understanding addiction better. And what we hope to do is to provide a standard of care, a way to help people from falling through the cracks. Many times a person might be identified as having problems with addiction. They may go in for treatment. There may be a wait period and they don't get in time. There may be, it may be that they get through treatment and there's not aftercare provided, and they tend to fall through the cracks. And as Dr. Patterson can tell you, many times they see the same people over and over again. We hope through the research that we do among our basic and clinical scientists here at LSU Health, and also with our community partners, that we're able to identify areas where people do fall through the cracks and help to increase the ability of people to get sober and stay sober. And that's really what LARC is all about.
Great, thank you. Dr. Patterson, would you kind of tell a little background about yourself and why you're here today?
Sure, I'd be happy to. I'm the clinical director of Louisiana Addiction Research Center, and it's been a really exciting year for us. We formed this center with, I think, maybe 30 days notice and got everything written up. The things that we need to do, that we want to do, that we were doing and we're going to do are going to be good for you, the community, you, the university, and our department, and everyone out there who suffers from addiction. COVID has kind of put us behind schedule on some of our outreach activities. We had a lot of things that we were planning on doing that we haven't been able to do. It's really hard to reach out into the community when, well, for example, why we're doing this here on camera instead of in person. But we're still doing it. We're still even more so now because COVID has had a significant impact on addiction, which I think we're going to get to in our presentation, our talk here. But we have a lot of things that we want to do. From my perspective, what I see in the ER every day is earth-shattering. And I don't think people understand how bad the problem is. I'll stop there.
And Dr. Murnane, would you like to introduce yourself?
Sure. My name is Kevin Murnane. I'm the Director of Basic Science Research within Louisiana Addiction Research Center. And this has definitely been a very exciting year for me because I just moved here from Atlanta, Georgia. And I moved here because LSU Health is one of the finest academic research centers in the country. There's only a little more than 100 academic research centers in the whole of the United States, and LSU Health is one of those. And the resources available to help people with addiction, which is something that I'm very passionate about and has touched my own life, my family's lives very deeply. It's tremendous here. The Addiction Research Center, the Cardiovascular Center, Cancer Center, the hospital system, the partnership with Oshner, being able to work with scientists like Dr. Getters and clinicians like Dr. Patterson. It's a really fantastic community that we're building here. I'm really excited to work with the community of Shreveport to help out this issue.
Great. Thank you, everybody. And I know I speak for everyone when I say that I'm thankful for all of you and your expertise today. Before we get started, I just want to remind you that you can leave your comments as we go on the YouTube page, and we'll try to answer those questions as they come in. But without further ado, we'll get started on our first question. So the first question is, how has the COVID-19 pandemic affected addiction rates and those currently in recovery? And we'll start with you, Dr. Patterson.
So, bad. It's bad. It's the best way to describe it. It's hard to get concrete, objective data on this. We know it's bad. It's an ongoing pandemic, and we've seen inklings in it in preliminary results that have been published. But when you think about just the stress of knowing that you're living through a historical event that's affected close to, over millions and is probably going to kill over 1 million. It impacts just thinking about that, having to wear a mask, knowing that you might be infected or you might infect someone else unknowingly. We saw a patient today who was anxious because of that, didn't want to go out in public because of that. And if you have an addictive disorder, one of the things that makes you use is stress. Well, guess what? We're living through one of the most stressful times in the history of the world, and certainly our current history. So it is bad. I don't know how else to put it.
Anyone else have comments on that question?
Let others talk now.
Yes, sure. I'd like to go ahead and speak up as well. I've spent most of my career in the laboratory looking at the relationship between stress and addiction, and this is something that's been known for years and years, that when people undergo periods of stress, they tend to be more sensitive to their addictions. So you may have someone who has gone through rehab, they've been able to be drug-free, and then something happens in their life, some sort of traumatic event, or something sets them off, some stressful event, and many times they will relapse. And that can be seen with relatively small things like a fight with your spouse, or having a bad day at work can be stressful. But then when you magnify that with something such as this COVID-19 pandemic, it makes it even that much worse. It was shown after previous traumatic events, such as the attacks on 9/11, and after Hurricanes Rita and Katrina hit New Orleans, that there were increased rates of alcoholism, cigarette smoking, marijuana use. So these are all documented in the literature. And I can only imagine what's going to happen through this pandemic and afterwards. But then there's an added, on top of the stress itself, it's harder for people to get treatment. Like Dr. Patterson was talking about, one of a patient he saw today was anxious about even going out in public at all. There are people who are afraid to go to the doctor because they're afraid they might get the virus by going to the doctor, which isn't true, but they still have this fear. And so a person may be less likely to go in for treatment for their addiction. Rehab facilities, I mean, you have to practice social distancing and all these sorts of things. Well, that's hard to do in rehab effectively. And so there have to be different measures taken in order to be able to treat people in their addictions without exposing them to further risk because of COVID-19. And then you have the 12-step programs. Many people who do go through rehab and go through treatment, they rely on Alcoholics Anonymous or Celebrate Recovery or other types of 12-step programs in order to maintain their sobriety. And that's hard to do right now because you can't meet in large groups of people, and when you do meet in smaller groups, you have to have a mask, you have to socially distance and what have you. And a lot of the small groups that you have in AA and Celebrate Recovery involve more closeness than physical closeness than you can experience right now during this pandemic. So it's making all phases, not just the etiology of addiction, not just the relapsing because of the stress, but there's problems on the treatment side as well that the virus is causing. And so this entire pandemic is just making the problem of addiction that much worse. And we want to get ahead of it if we can. And I ask anyone who is listening today, if you have any ideas for ways that can be put into practice to help address these problems, that's what we're all about, because we are a research facility and we rely on knowledge from the community as well as what we are able to ascertain ourselves.
So I can add to that just a little bit, but we are, of course, using what is called telehealth or telepsychiatry in a very big way. But the psychology of a support group is based in large part on in-person, face-to-face visits. You can replicate that a little bit with, you can do groups online, just like we're doing now. But when you're an addict, when you have a substance use disorder, being in the same room with someone who's there, that you're keeping them accountable and they're keeping you accountable, it's different. The psychology is very different in those kinds of groups. And so it's not, I'll say it again, it's not good.
I think I'll just add one thing, which I absolutely agree with Dr. Patterson, and particularly Dr. Patterson's point that we don't have hard data yet. One of the research projects the Louisiana Addiction Research Center is developing is to try to figure out some objective ways to see how much substance use is going on in the community and how that's changing with time, whether it's going up or down. It's probably more likely to be going up right now than going down. And whether the types of drugs people use is changing, whether switching from one type of drug to another type of drug, perhaps because they can't get access to drugs they used to use, or there's cheaper or potentially more dangerous drugs available. So we're working on a research project to look at that objectively, and we hope we can then expand out to North Louisiana, maybe the whole state of Louisiana, and eventually try to make it a model for the country to use.
Thank you all so much for that. So to move on to our next question, this is probably targeted at you, Dr. Patterson, with your clinical director title. So it says, what should I do if I witness someone who I think may be in a drug overdose, and what is Narcan?
Sure. So first off, if it's an overdose and they're passed out, then the very first thing you need to do is to call 911 and resuscitate the patient. I highly recommend that everyone who is listening to this get some basic life support training. But the treatment for someone with an acute opiate overdose is an injection of Narcan. And that's why in many places around the country where there's significant opiate problems, or even with patients that are on high doses of prescribed opiates, they will give them a Narcan kit, which is an auto-injectable dose of Narcan. And it counteracts counteracts the effects of the opiates and wakes the person up so that they can start breathing again. The problem is that when you overdose on opiates, you stop breathing and you die. This is not good. And so you want to keep them alive, and Narcan pens will enable you to do that. While there may be instructions on how to use them, it's pretty straightforward. You inject it into their body as best you can. There might be instructions on the side, but anywhere you can is better than nowhere. So the best thing to do is to call 911, resuscitate the patient, use Narcan if they have a pen on their body or you have one on your body, and get them back awake and breathing and into the hospital as quickly as possible.
Thank you. Okay, so our next question is, what is the difference between recreationally abusing a drug and substance dependence?
Okay, I'll start on this, and I'll let the others chime in after this, because as I think all of us, addiction has hit close to home with me, as well as I dare to say there's not anyone that hasn't been affected by addiction, either personally or in their families or a close friend. But it's a fine line, I think, between recreational use and addiction. And I say that because both of my parents were alcoholics. I didn't know it at the time. I didn't know I was growing up in a dysfunctional home. I just knew, or looking back on it now, I didn't think anything of it at the time. But looking back on it now, they were drinking every night and drinking a lot every night. And it was more on the weekends and it was more on holidays. And I think that's why now I've got a difficulty of getting excited about holidays, because I guess I just have that history so long ago that was a time to drink more. And so drinking in general is a socially accepted, at least in this country, it's acceptable to drink. In fact, there are things going on now that the governor is doing to let bars open, but if they're serving food, because the bars themselves aren't allowed to be open during this phase of the pandemic. And I heard the governor speaking today that if they're serving food and maintaining the same restrictions that restaurants do, then they could be open. But I'm getting off the point here. Drinking is socially acceptable, but yet when it goes to excess, when someone is drinking and it's taking them away from their normal lives with their family, it's taking them away from their job, they're too drunk to go to work, or they go to work drunk and they get fired, then it has progressed from a recreational activity. I mean, I guess there's nothing wrong with having a few beers or a glass of wine. You could do that every day. But when it starts interfering with your life, it starts interfering with your activities with your children, your family, your job, then it becomes addiction, because you continue to use the drug despite the problems that it's causing. And those can be social or medical. And the same would hold true with other drugs, the drugs that aren't legal, that aren't so socially acceptable. Those drugs, perhaps someone can use cocaine recreationally. I would never, ever tell someone that they could, but apparently there may be people that do. When you get to other drugs, such as methamphetamine, I've been told, again, I have no personal experience, but I've been told that you can use it one time and become addicted after one use. Another drug that is used to be socially acceptable, if you look at movies from 30 years ago, it seemed like everybody in those movies was smoking cigarettes, and now it's completely unacceptable to smoke cigarettes, but those are also very addicting, and you can go from having a cigarette after meals or something to where you're chain smoking. So it involves how the use of the drug, how the recreational use of that drug begins to take over your life. And I'll go ahead. I know I'm rambling on. I'll let Dr. Patterson tell you more from the clinical side.
So the single most addictive drug in the world. It's not amphetamines and it's not heroin. It's nicotine. And I would caution you not to try and smoke socially because it is definitely possible to get what you would call addicted, although there are different definitions of addiction, with just one cigarette. It's an incredibly powerful drug. So keep that in mind. Nicotine is incredibly dangerous. Smoking is bad for you. I can't tell you how many different ways it's bad for you, how many different kind of cancers. Both my father and my grandfather died of kidney cancer. The only known risk factor is smoking, and they both smoked pretty much all of their lives. So it's something that I don't do once I learned that. I had to quit long, long ago. But the most recent data on alcohol indicates that there's not a safe limit, that it is associated with a variety of different health factors, including cancer, including other diseases. And the more you drink, the more those increase. Whereas there's also data that shows that drinking in very light moderation can have some health benefits. And so you really have to balance that with clinical history, family history, etc. There are no safe levels of smoking. There are no safe levels of cocaine. There are no safe levels of heroin. We hear right now we are in what's called an opioid crisis, although it's kind of fell off the back burner because of the COVID crisis. But people are dying in large numbers because of overdoses on opioids. It's not as big a problem in our area as methamphetamine is, but it's still a significant problem. And the story I see coming into the emergency room to see a psychiatrist for detox is getting started on a pain pill because of, a tooth extraction, a broken finger, a broken arm, anything like that, and they realized, wow, these feel really good, and then they get addicted. And the stories behind that, the wrecked lives behind it, the wrecked families behind that, stretch on and on and on. So it's important to realize that the medicines we prescribe as doctors can be as addictive and as dangerous as the illicit drugs that you get on the street. You got to be careful there as well. I'll let Kevin talk a little bit. I can go on and on about this topic.
So I absolutely agree. I don't have anything different to say. I'm just going to add a couple of things, I think, which is that craving the drug is a pretty important part of addiction. As Dr. Patterson said, any kind of use of these drugs can be very dangerous, very bad for your health. But when you are using it, you're starting to crave it. You're starting to desire obtaining it when you're not on the drug. That's a pretty clear sign of a transition to addiction. And there's sort of two aspects of that. One can be physical dependence, as Dr. Patterson said. People break their backs, or they have other pain, they come in for medical care, and they are initially appropriately prescribed opioids, but as they're on them for too long, or they start escalating the dose of the opioids to control the pain, people can get very, very intense craving when they're trying to come off the pain. That happened to a close family member of mine who had an injury and was on opioids with a patch form fentanyl that was prescribed. And it was very, very, very difficult for her to come off the opioids because of the intense craving that she experienced when she was not on them. Other drugs don't necessarily produce physical dependence, but they can produce very strong psychological craving. That's more true with things like stimulants like cocaine and methamphetamine, where you may not have as clear physical signs of dependence, but you'll have very intense psychological symptoms of anxiety, depression, craving coming up. So when people start to go from use that's not good, but start to get into where they really feel like they need to go obtain the drug when they're off it, that's a pretty clear sign of transition. transition to addiction.
Thank you. We have a couple comments on the YouTube page that we wanted to go ahead. Dr. Patterson, did you have something you wanted to add?
Sure. Thank you, Jean, for that comment. Yes, there is not just an EpiPen type of injector from naloxone, but a Narcan kit that's a nasal spray. Good to know. Good to get that information out there. And we have a question. How can we help people when they are in denial of an addiction? This is kind of in the form of a joke, but it's not really. But I tell this, and I use this all the time. How many psychiatrists does it take to change a light bulb? The answer to the question and the joke kind of is only one. But the light bulb has to want to change. And so when you have someone who's in denial of addiction or doesn't want to get help or doesn't want to change, one of the things you can do is help yourself. It's one of the most important lessons that we tell people is that it's incredibly difficult to change someone else. You can change how you react to someone else. And so for those, for example, who are addicted to alcohol or who are married to an alcoholic, going to Al-Anon as a support group for you is a great thing to do. And you can get all kinds of resources there. And they have those for Narcanon, for narcotics, things of that nature. So the support groups for those living with someone with addiction is important. But we, just to use my own experience as a physician as an example, there are several types of family dynamics that we see as a result of long-term addiction. It's the families who love somebody and they love them a lot and they keep enabling their use. They will take them in, they will feed them, they will clothe them, they will get them detoxed, they will get them taken care of. And that person takes advantage of all of that, leaves the next day and goes and uses again. And on the other side, that's bad. Okay, I don't want to say that that's good. But even worse than that is the family that has completely abandoned their family member. We want nothing to do with him. He's burned all of his bridges. We don't want to talk to him. Nothing. We will not give him anything. And so there's a balance there. Back in the day, there was this phrase that I love to use, and it's still important. It's called tough love. It's very good. You want to tell them that you love them. You want to say that we're here for you when you get clean, but we are not giving you the resources to enable your use. If you want to get into treatment, if you want to get into therapy, if you want to go see a doctor, we'll help you with that, but that's it. And it's really hard to lock the door in the middle of the night. Sometimes it's what you have to do.
If I could just chime in on that. That was something I lived through growing up. On those weekends, I told you the weekends were often hardest. And my father would come in very late, and my mother would lock the door, and he would be outside. And first he'd be yelling for her to let him in, and then he would change to me, and it was really hard as a child to offer that tough love that Dr. Patterson's talking about. But I think that had an influence on me later on, though, and tended to change my heart to where instead of being tough against addiction, well, I'm not saying not to be tough, but I'm saying it's opened my heart to want to help people who are suffering from addiction to do things like the LARC and try to put people together and bring people together in order to solve this puzzle. It's something I've been trying to solve for 40 years in my academic career. And now by being able to go across, as I said before, the departments and centers here at LSU Health, but also to bring in people from the community who can interact with us and give us more insight. That's what, it's not just an intellectual exercise for me. It's something that comes from the heart, and I think it's from, in a good degree, growing up in that environment. And I just had a funny, not a joke, but funny thought that, Dr. Patterson could end up charging me for this if I go on much longer. That's what the LARC is all about. All of us here on the executive membership, everyone on the board, including you, Anna, and all of our community partners all want the same thing. We want to be able to come up with a way to better treat people, whether they're in denial, maybe to give them the education they need to realize that there is help out there. One reason people often get it, well, there's so many reasons. One reason that people sometimes stay in denial is because socially for so long there's been a stigma about addiction, that if you're an addict, that just means you're not strong enough, you don't have enough self-control, you don't have whatever it is to just stop drinking or stop smoking or stop sniffing glue, as they said on the movie Airplane. It's more than that. Addiction, when someone takes a drug, even for the first time someone takes a drug, it's going to begin to affect the brain chemistry. And when the brain chemistry is affected, there are dynamic changes within the central nervous system, within the brain. And if someone then stops using the drug, the brain doesn't know what to do because it's adapted to the presence of the drug. And so addiction isn't just a moral failing. It's a biological phenomenon. And so there are so many factors involved in trying to help people recover from their addictions. And that's what LARC is about. And boy, I took a long way to get there, but I'm sure Dr. Patterson's going to want to chime in, and Dr. Mernan on the biological side of addiction.
I'll let Kevin talk for a minute, then I'll answer that question that just got out there.
Sure. I'm actually going to talk about the psychology a little bit. Maybe I shouldn't stick to the biology. But one reason people might be in denial is because facing the problem could feel overwhelming. So people will tend to deny it as an issue rather than facing such a thing that seems so intractable, it's so difficult to do. So you might be curious what Dr. Patterson thinks about this. You might be able to get them out of denial by giving them hope that their lives will be better and that this is addressable and that things can change and circumstances can get better and the world be a better place. And that might help them to cope with the problem in a way that seems more manageable than if they don't feel like there's a way out of their problems.
Yep, I definitely think that's important. Hope is incredibly important. And the scariest patients that I see, the ones that I worry about the most, are those who have lost hope, because that's very scary. I worry about suicide very much when I see that. But, so yes, that is important. So I'm going to answer Connie's question, and it's a two-part question. I'm going to answer the second part first. Is it possible to treat addiction without substituting one thing for another? Absolutely it is. Yes, you may. Yes, you can. And in many cases, it is the recommended way of doing it. And in fact, the only way of doing it. The first part of the question is, do you find that patients treated with Suboxone then in turn become addicted to using that instead? And that's a really important question. And so in the field of psychiatry, the old school of thought is that this is not a good thing to do. It's just going to get them addicted to using something else. And it's not really helping them get beyond their addiction. And there are many people that still are in tune with that school of thought. And there's something there. I mean, it's a philosophy. But there's also the benefits gained from getting someone off the street from using heroin, from using illicit and illegal drugs, and overusing abused or prescribed drugs, and so that they are in a controlled environment using a substance that is controlled and that has a much longer half-life to keep their physiological dependence and their addiction in much better control. It gets them out of harm's way and in treatment and on the road to recovery. So I see some benefit in it. It is a balance. It can be misused. And in fact, the pills called buprenorphine, they have street value. Okay, so they are not without risk in and of themselves. So I don't find that most patients treated with Suboxone get addicted. They do continue to have, to some degree, a physiological dependence on the opiate. There is a difference there between dependence and addiction. Addiction is a syndrome that's characterized by not just dependence, but spending your entire life, mostly, either getting the drug, using the drug, recovering from using the drug, or obtaining more drugs so that you can use them. It typically involves losing your job, losing your family, multiple hospital stays for overdoses, things of that nature. That's what addiction looks like. And so you can maintain your life and your recovery on a medication like Suboxone and work and be a productive member of society. So it does have its problems. It can be misused, but it's definitely a good tool to have in our toolbox. Because in the field of addiction psychiatry, we have very few pharmacologic tools to work with, and we need more. And that's one of the things that LARC is doing. Is we're trying to find better tools, more treatment mechanisms, whether they're therapy, whether they're pharmacotherapy or psychotherapy, more models of care. We need to find better ways to treat those with addiction because we don't have very many tools.
You touched on half-life, and I think that's something that maybe we could describe a little bit better for the community when we're talking about drugs like Suboxone or more commonly methadone is what we see a lot around here for opiate abuse. Can you kind of describe the difference between these drugs and the drugs of abuse based off of what we're calling the half-life?
Sure. I'm not going to get too detailed here, but drugs of abuse like heroin and pills that you can be prescribed or buy on the street like Xanax, they have a very fast onset of action, especially if they are injected into a vein. And so that is what drug addicts are looking for. They want that rush, that hit, that release of dopamine into the brain, which makes them feel high. Medications like Suboxone, buprenorphine, they have a much slower onset and longer duration so that you still have the sustained effect of the opiate medication, but you don't get nearly as much of the high, quote unquote, that you get with injecting heroin, for example. Hopefully that answered your question.
Yes, that was great. Thank you for that. Did anybody else want to comment on that question?
I agree with Dr. Patterson that that's a very important issue. That it's not just what the drug does pharmacologically. It's also the speed at which it does it is very, very important. And methadone has a very long half-life, which is why people usually go to methadone clinics just once a day. They take it as like an oral or a formulation. And why methadone would have inherently less abuse liability than something like heroin. And just like Dr. Patterson mentioned, that is part of why what we would call harm reduction is important with methadone. That people are less likely to go out and compulsively use methadone or to be committing crimes to obtain methadone or to have other intense craving feelings with methadone compared to something like heroin or synthetic opioids or even prescription opioids like oxycodone. So those pharmacokinetic parameters are helpful in designing the few medications we have.
Thank you, Dr. Murnan. Before we answer these questions, I kind of wanted you to touch on something that Dr. Patterson mentioned, and it was the word dopamine. So that's our big neurotransmitter that we talk about with a lot of these drugs. Would you mind kind of explaining the mechanism of dopamine and how it relates to addiction?
Sure. Our brain is composed of little cells called neurons, and those cells sometimes communicate with each other with electricity, but most of the time they communicate by releasing small chemicals between one another. So one cell releases a chemical, and then it travels through the fluid in your brain and hits the next cell where it hits a thing called a receptor. And dopamine is one of those chemicals. It gets released from some dopamine cells, which produce the dopamine inside of it, and travels through this little fluid space and binds up to those dopamine receptors. And we don't fully understand everything dopamine does. It's certainly involved in rewarding feelings and euphoria and rush. It also seems to be a molecule that helps your brain tune to certain stimuli, so things that are things worth paying attention to. Seems to be a natural way of tuning your brain towards stimuli. It's also involved in cognition and executive function and other things, so it's has a lot of different activities. But one of its key activities is in this reward pathway that seems to be central to all of these drugs of abuse. That pathway is what we call in science a circuit. So there's all these little circuits of connected neurons in the brain that do different things, mediate different processes, and allow you to do different functions. And this reward pathway is the one that's very important for all the different drugs of abuse. And not just for drugs of abuse, it's also important for eating, and it's involved in compulsive shopping, compulsive gambling, and it's an important natural system in your brain to tune you towards different stimuli. The problem is that drugs of abuse activated way more than natural reinforcers or natural stimuli in your environment do. And then that hyperactivation hijacks your brain and starts to send you towards compulsively using the drug. And all these different things we've talked about clinically that play out where people start to, as we talked about earlier, have problems with work, have problems with their family, and have problems with their activities of life because their dopamine system is directing all their behavior towards obtaining the drugs of abuse and neglecting all these other important parts of your life.
Thank you so much for that. Such a pivotal, important point to know about addiction. So we've got a few more questions on the YouTube page, and the next one is something that I advocate for a lot, is the family members of addicts. That's someone that kind of gets looked over when it comes to addiction. And this question says, can you please discuss the importance of treatment for the family members of addicts and how enablers have to overcome the innate need to fix things? So how do you ride that line between enabling and being supportive of your family member or friend?
Well, I guess I have to address that since I started that. There is a thin line. There is I'm not giving you money, but I will take you to the hospital. I'm not going to give you a shelter. You're not going to sleep here, but I will, pay for you to go to treatment. There's things you can do, things you can't do, things you should do, things you shouldn't do. And getting the family into treatment is something it's worth discussing in terms of family therapy, because addiction can rip a family apart. really can. And so not just going to Al-Anon or Narcanon, but going to family therapy. It's like, our dad has destroyed our family. Our family dynamics are, they're built around whether or not we can talk, whether or not he's drinking, whether or not mom is using, whether or not mom is there or has gone down to, inject heroin. Those are things that can rip families apart, and so it is very important. Our society does not really think about psychotherapy or getting preventative care. You go see your doc sometimes for a well check, make sure you're doing okay. You ever go see your therapist to make sure you're doing okay? Just something to think about. And when you know something's not okay, what do you do? So there are different things you can do. If you're, spiritual, religious, or you have a church or a temple or something that you're involved in, go speak to your faith person, your pastor, your reverend, your rabbi. If you are, in a group, go talk to your group. But definitely don't do nothing and ask for help.
If I could, I would like to add, everything Dr. Patterson said is absolutely correct, and counseling and group therapy and all of those sorts of things are very important. But another option, and I know about this because we started one out at our church, it's similar to Alcoholics Anonymous, and they may have this in Alcoholics Anonymous, but in Celebrate Recovery, which is another 12-step program, it's not just for addicts. It's also for people who are enablers, or they call it in Celebrate Recovery codependent, that they're spending all of their time trying to fix others, the way that Connie phrased it in her question. And as Dr. Patterson said early on about psychiatrists, it only takes one to put in a light bulb, but the light bulb has to want to be screwed in. We can't make anybody do, well, it's close. We can't make anybody do anything. And if someone is stressing and their life is out of control because they can't get their husband to stop drinking, or they can't get their wife to stop going down by the river and injecting heroin, well, they have to learn they can't fix that. And in psychotherapy, group therapy, or in groups such as Celebrate Recovery, you can learn that you can't fix that. You can't fix someone, and you can learn how to let that go and certainly offer whatever there is available for your family member or your friend to get better. But you can't make them do that. They're going to have to want to, and you have to learn you can't fix it. I also had a friend who started off with a bad back, and he was given pain pills, and he ended up developing an addiction. And I had a friend, and it was Dr. Patterson or someone else who, this was so many years ago, and was able to get him in that treatment program, but the Wednesday before he was scheduled to go in, he overdosed and died. And I'll never forget that. I wish I could have done more, but there was nothing more I could do. That was his choice to do that. And so we have to learn we can't fix everyone. We can't do that ourselves. They have to want to be fixed.
I would just say that's a really great idea. Having someone you love that suffers from addiction is traumatic. It's traumatic because the disruption to your life. It's traumatic because of the fear of losing your loved one. It's traumatic for all the chaos it might induce in your own life if you try to help. And trauma produces bad psychiatric outcomes if you don't address the trauma. And it's also probably very important for the person with addiction, because one of the most important ways for them to come back is through their loved ones. And if their loved ones are so traumatized by the problems, their ability to help their loved one come back is not going to be as gracious as they can overcome that trauma. So I think that's a really, really important thing.
Yes, thank y'all for that. Such an important point to mention is that you don't have to suffer in silence when it comes to having a family member or friend that suffers with addiction. We often say so many people in the room, out of everyone in the room, most have been affected by addiction, or someone that has. So it's just important to know that you're not alone. I just wanted to add my plug in there. But so we've got some more questions on here. And this one's directed for Dr. Murnan to talk about the research that LARC does or plans to do about how the pandemic is affecting substance addiction, and has this research already started. So I know we are the Addiction Research Center, so we have tons of projects going on, but this is probably a question for all of you. I want to jump in, but we'll start with you, Dr. Murnan.
Sure. So there are tons of things going on, and I wouldn't be able to tell you every one of them in just this one session. We've got more conversations about it, but I'll tell you about one, which is we started a project to see if so we know it's very likely that the social isolation and the stress of coronavirus is likely to increase substance use patterns. But there's starting to be emerging evidence that people who recover from the virus also may have some long-term health outcomes. There's very widely cited paper that just came out, and the Journal of the American Medical Association looking at how people who recover may have long-term heart damage after they recover from the coronavirus, because the virus produces a really intense inflammatory response throughout the body, not just to the lungs. And we know that inflammation of the brain can lead to bad psychiatric outcomes. It can lead to depression and anxiety and substance use and other more psychiatric outcomes. And so we started a project to see if exposure to the virus may result in those sorts of bad outcomes in the brain, which would be not good, but better we understand it than just ignore it. And then more hopefully we would try to develop treatments that would mitigate that and hopefully reverse some of those pathological changes that make people more predisposed to bad psychiatric outcomes.
Dr. Getters, did you have a favorite project that's going on right now you'd like to tell the public about?
It's a good question. Favorite project going on right now. It's really hard, or it has been really hard since the start of this pandemic to get out there and do the types of projects that we want. But one thing that is in the planning stage now, and in fact, we have a meeting coming up right after this session here, is to work together with the Cardiovascular Center, the Center for Brain Health, the Cancer Center, and put together a project to look at the effects of methamphetamine and opiates on the cardiovascular system. We know that meth can have serious dramatic effects on the heart. We know that cocaine can as well. But what we also know, and Dr. Patterson, I believe, alluded to this in some way, and if not, I'll say it now, is that people will use what they can get. If their drug of choice is methamphetamine and they can't find methamphetamine, they'll shoot heroin instead. And we think that the combination of using a drug like heroin and a drug like methamphetamine can produce additive effects on not just the brain, which we are going to study with Dr. Patterson and the Center for Brain Health as well, but also on the cardiovascular system. And people are dying in their 40s with congestive heart failure and other serious cardiovascular diseases that you normally don't see until people get old, not like me, but really old. And so you don't see that typically unless they're using drugs such as meth or heroin and those types of drugs. And since people often will use combinations, or they'll use whatever they can find today, it may be that they're producing a significant additive effects. That's something that we want to look at. And and document and have the data available here at the LARC for people across the country that they can come in and mine our data and use this to develop ideas where they are, wherever it may be, east to west in the United States.
So I'm going to answer the next question and address a favorite research topic of ours in one setting because we have 5 minutes left. How can we educate the public about how serious addiction is? Well, we're actually doing it right now in this forum, which was the brainchild of Anna Rogers. So Anna, thank you for doing this and getting us up here. And this has been a great experience. So we do need to educate the public more about how serious addiction is. The problem, our country can talk about in the news, they can talk about many things. And it takes people dying, really, to get their attention. And so that's how the opioid crisis hit the news. And it's important to realize that many of the people that use drugs don't die. And many of the people affected by drug use aren't even using drugs. It's the families. So the public education about that is one of the I would say one of the foundational components of our research center. Not just to educate, but to research on better ways of educating. Outreach programs, models of care, how to get patients, how to get families into care. One of the things that has struck me, and I think Nick touched on this earlier, is that the stigma of mental illness, it's better now than it used to be. But the stigma of addiction as a component of mental illness, it's still very bad. People are embarrassed by being addicted. Back in the day, people were embarrassed by being depressed. And there is still a component of that. Or they were embarrassed because they have panic attacks. But just imagine telling someone that you're an addict, that you can't stop drinking, that you can't stop using. It's hard. And so educating people about how serious it is important because overcoming that stigma is really a big challenge for us. So it's very important.
Thank you, Dr. Patterson. Did somebody want to say something else? Okay. So we do only have about 2 minutes left. Again, I just want to reiterate how important it is that Dr. Patterson said. Let's talk about addiction. I once did a research project called that. It doesn't have to be a stigma. We can talk about it. We don't have to be embarrassed about it. And just like Deborah's question, how do we educate the public? We educate by talking about it and making it a conversation. So that's how you can help too. But this leads us to our very last question, and this is for you, Dr. Getters. If you're interested in helping LARC combat addiction, how can someone become involved with our organization?
Well, anybody can be involved. We have our website. It's the Louisiana Addiction Research Center. I think if you Google that, you'd be able to find it. I couldn't give you the website off the top of my head, the address. But you can come there. You can become a member. You can become an affiliate. And as I said earlier, we welcome our community to give us ideas. What are things that we're missing? But we're only human, each one of us, and so provide us with ideas. And if there are ways that we can get out into the community and educate, if you want us to come and speak to a group, any one of us would be happy and come out there and speak. Oh, there it is. And speak to a group to educate, if it's your church group or your school or any type of a group that they want to learn more about addiction or they have questions, we could come do a question and answer or set something up virtual, I guess now until we after the pandemic. But we just ask you to join us. You can be part of the LARC as a community friend, a community member. And I think that's the best way to help is with your ideas and becoming part of us.
Okay, well, thank you. Go ahead, Dr. Gitters.
I was just going to say, someone gave me a cheat sheet. The website is www.lsuhsc.edu/LARC. And that's our website. You can find out all about us there and become a community friend or member, and or just send us ideas. There's a link for sending us email ideas and questions as well.
Yes, so thank y'all so much. Thank you to our experts. It's been really great. I'm glad we were able to get together and do this and educate the public more. We would love to do this again. If y'all are interested, please go to our website. There's a comment box. You can tell us, your comments, your concerns. If you'd like to see us do this again, the topic is endless. We could talk about addiction for days. So just let us know what you think. And again, we thank everybody for watching now and the future, and we appreciate each and every one of you. Thanks, experts.